The following podcast is part of a certified educational activity titled Shifting to Higher Standards in MDS, Custom and Innovative Care to Improve Outcomes for Lower and Higher Risk Disease. Access the entire activity and complete the post-test at peerview.com/XNT860. Downloadable slides and practice aids are also available.
Good morning, everybody, and welcome to this symposium at the ASH 24 in San Diego. So we're going to be talking about myelodysplastic syndrome. As you can see here, the title of the session is going to be Shifting to Higher Standards in Myelodysplastic Syndromes. We're grateful to PeerView for putting all this together and organizing what I think is going to be a really interesting symposium. So I'm actually also extremely happy to be here with not only my two really esteemed colleagues, but friends, Dr. Maria Diaz-Campello, who is actually the leader of the MDS group in Spain, in the University of Salamanca, and with Dr. Valeria Santini, who's the Italian leader of MDS in Florence, who I think we've been together now close to 20 years trying to improve outcomes in patients with MDS. So thank you very much for being here. These are our goals for the session today, basically to improve your knowledge of clinical and molecular features of MDS that can inform prognostication and treatment planning. Hopefully, we'll also enhance your understanding of evidence supporting the use of newer therapies in both lower risk and high risk myelodysplastic syndromes. We would like to increase your skills for collaborative team-based treatment selection. And finally, equip you with the skills you need to manage dosing and safety considerations of the therapies that you may use for patients with these disorders. You saw the video a few minutes before we started the session about the HealthTree Foundation. I'm not going to read these slides, but basically the goal of this organization is to empower MDS patients, and hopefully this will result in acceleration of a cure or improvement in outcomes for our patients. As you heard earlier, basically this is kind of an innovative platform that powers life-saving research, and they have a significant track record in multiple myeloma earlier. And with that introduction, I'm really honored to introduce Dr. Maria Diaz-Campello from the University of Salamanca, and as I mentioned, a world leader in MDS research, to give us the first part of the symposium. Thank you.
Thank you, Guillermo. Good morning, everyone, to be here very early this Friday and this amazing ASH meeting, one more year. Let's start with this first small introduction regarding the needs for upgrades in patients with MDS. Let's start with the presentation. Here you can see the two patients that we are going to address by Dr. Santini and Dr. Garcia-Manero. They are two patients newly diagnosed of MDS and identified and diagnosed with the presence of isolated cytopenia, that is anemia. And when we perform bone marrow, we identify that the male patient is in the lower risk setting based on the morphological findings of ring sideroblasts, no stereoblast, and S3B1 mutation, while the woman is in the high risk presented with high risk features based on the presence of stereoblast and adverse somatic mutation. The questions for my colleagues could be, how do you think in this lower risk patient, how common is this presentation of these patients? And if now that we have these two classification systems for diagnosis, do you think that the same entity could be identified in both classifications? Also, we'd like to address with you if this is necessary in this type of patient that we have this specific mutation to perform a panel of molecular markers by next generation sequencing, and if this is the standard of care of these patients, and if we should calculate IPSS-M in order to identify better the prognosis. What do you think, Valeria or Guillermo, briefly?
Okay, I start. The presentation of Eric is quite common. So it's 76-year-old is the median age for MDS, fatigue, macrocytic anemia, and of course you already found additional values that are of great interest. The most important one is SF3B1 mutation, which means that you evaluated the patient with molecular NGS or Sanger, and it could be done as well. But the diagnosis here is not so different from ICC and WHO. It's actually including SF3B1 mutation and 17% of ring sideroblast, so it will be more or less the same. It's just a matter of language. I don't know if you agree, Guillermo.
Totally.
Okay. Thank you. Regarding the high-risk patient, probably the same question should be addressed. Do you think that the diagnosis could be similar using ICC and WHO classification? And what is the role of ASXX1 mutation in this patient? And do you find that this is necessary to perform in these high-risk feature patients to perform the molecular IPSS, or is not necessary, Dr. Garcia-Manero?
Okay, so here I'm going to maybe confuse the audience a little bit. Maybe Dr. Santini will disagree with me. So here is where I am not sure that the ICC is correct. I think MDS is not AML. I think MDS is a disease of a very primitive stem cell. And I think trying to get classifications because the therapies may be more or less intense doesn't really make sense. But I think I'm the only one right now in the world thinking about this.
No, I completely agree. I support.
So if this person had 11% blood, someone here will say, oh, this is AML. So I don't think this is really correct. But that's my personal opinion. The second point is the AXL1 mutation. This may not be known by the room or the audience, but I think this is quite important, actually. So there was some early evidence 2 or 3 years ago where patients with these kind of mutations were sensitive to BCL2 inhibition, for instance, with venetoclax. And we've been able actually to reproduce that very much in our studies at MD Anderson with ASA venetoclax, the oral decitabine cedazuridine venetoclax, where we see extremely high rates of response to venetoclax combos with the HMA in the context of this mutation. So we use this actually as a sensitivity biomarker of this type of combination. So I think that's important. And then the other thing that is going to confuse the audience is about the IPSS-M in this group of patients. So the IPSS-M is the best tool to predict what the outcome is going to be on a patient that is hypothetical, maybe outside the context of therapy. But actually, we have data at this meeting over the last year and throughout collaboration where actually patients who are treated with an HMA, may not really benefit 100% from IPSS-M calculation compared to IPSS-R. We can discuss this why later. Basically, you're not really going to make a distinction in terms of therapy based on the molecular features of that patient if you're going to use an HMA-based therapy. So it's a little bit controversial, but the bottom line is I think you should use WHO criteria. XL1 may be a biomarker of sensitivity to venetoclax on these patients. IPSS-M is a fundamental scoring. I think you're going to be discussing this. But once you start therapy, it may not really change outcome, very much.
Okay, thank you. Very, very, very clear. Let's start revising how recent development in NDS are changing the NDS care. And as you can see here in this slide, in the last 4 years, we have assisted to the approval of 4 novel therapies in this setting, 2 in the lower risk setting, luspatercept and this year imetelstat, and 2 in the high risk feature. The oral formulation of hypomethylating agents, decitabine plus cedazuridine, is approved in United States, and also ivosidenib as a target therapy for patients with mutant IDH1. These treatments also are going to improve the care of these patients. Also, we have, as we have previously commented, 2 novel prognosis classification systems that appear in the same year and that confuse probably not only physicians. And also we have a novel tool for prognosticate the patients, that is IPSS-M, including molecular markers to identify better the prognostics of the patients. Let's review how are changing our approaches. Regarding the lower risk setting, as all you know, the main goal for these patients is not only to improve quality of life. It's necessary to improve quality of life for these patients, but the major goal for these patients is to improve overall survival. As all you know, that when the patient becomes transfusion dependent, overall survival is dismal and inferior to those patients that retain transfusion independency. So we are going to try to treat the patients in order to reach transfusion independency with these novel drugs. In this analysis presented in the last EHA meeting by Dr. Malkovati, they identify in more than 1,000 patients receiving novel therapies that the goal to reach transfusion independency increases overall survival for those patients responding to the novel drugs, and this benefit was associated with an improved overall survival, not in the short, but also in the long-term follow-up. And as you can see here, 5 years after the initiation of the treatment, near the double of overall survival is expected for patients that reach this goal of transfusion independency, probably traducing that this is patients that are reaching transfusion independency are more feasible, probably more likely to respond, and they are presenting features of the disease more likely to have a better outcome. Interesting also in the lower risk setting is to improve the knowledge about the transfusion burden, because transfusion dependencies are going to impact patients and also caregivers, quality of life, work time, and several other issues related to different domains. And in this sense, we have performed an analysis identifying the transfusion burden in patients and presented this data in the last CHA meeting. And in this ASH meeting, we are going to present tomorrow morning. I invite you all to assist the impact of this transfusion burden also in caregivers. In general, transfusions are impaired quality of life of patients and caregivers, are impaired the work productivity, and also is a very time-consuming for both patients and caregivers. And probably if we are able to measure very good this impact, probably the treatments that sometimes are too expensive for payers are going to be seen in another way, and less difficulties in several countries could be address in order to pay these treatments. Regarding the high-risk treatment, here you can see that the results has not been improved since 2008 with the approval of azacitidine in this setting, even that we have used more than 50 novel drugs in different clinical trials. The last drug that failed last month was tamibarotene, and we need really to improve the results of these patients. There is an urgent medical need for these patients that we should address. How can we start? We can start probably with improving the tools for accurate diagnosis and prognostication of the patient, because probably we have the patient very good diagnosed, specifically in a specific subtype, and with identifying very good the prognosis, we are going to probably identify better the benefit of not for each novel drug. Let's review diagnosis criteria. Here you can see that the definition of MDS is based on the presence of cytopenia. All values under the normal values are defined as a cytopenia, and we need in these patients also to start a complex process with different studies in order to exclude other causes of cytopenias or dysplasia. Finally, when we have all these tests performed, we can diagnose the patient with when the patient have a MDS decisive criteria, and these are based on the presence of dysplastic cells, the presence of scessoblasts, abnormal karyotype, and or evidence of clonality. Interestingly, and especially in the lower risk setting, it's probably mandatory to have the confirmation of clonality, especially in those patients with no scessoblasts or no abnormal karyotype, in order to identify that this cytopenia is confirmed to be a neoplastic event and not secondary to other known clonal causes. Here you can see the two novel classifications that appear in 2022 and that we have previously commented. The update of the WHO classification, we are very happy always when this classification appears because it's generally very well updated and with several improvements for the diagnosis of the patients. The problem in 2022 is that a novel classification appears based on the International Consortium classification, and we have at the same time two classifications that are sometimes, even that they have several similarities, the majority of the times have several discrepancies. Let's see, because similarities probably are in this file. These entities genetically defined are the same in both, the same epigraph have the same names in the both classifications, del5q, SF3B1, and TP53. Only is the same in the entity of del5q, and there are several discrepancies in these two other categories. And this precludes that the same patient could be diagnosed in different ways by these two classifications. Also, there are several discrepancies regarding, for example, the terminology. WHO classification includes the terms of neoplasm to identify that these are not cytopenias. They are malignant clones that induce these diseases, and it's probably necessary to be registered patients appropriately in a cancer registry, and also probably is necessary for reimburse different bills of treatments. Regarding the dysplastic lineage, for example, is also not necessary in the WHO classification, and is a basis for diagnosis in ICC. And the major issues is regarding the morphological defined subtypes. Included in WHO classification is MDS with hypoplasics and with hypoplastic chains, MDS with fibrosis, identifying a specific subgroup of patients, and the major issue is related regarding this classification of patients with more than 10% of labs and less than 19. As Guillermo commented, WHO classification retained this entity separately for AML based on the fact that these patients are completely different. For AML patients, they are generally older, with a low bone marrow reserve, and with a no tolerability for intensive therapy. And even that the fact that some drugs that have demonstrated efficacy in AML has not been reached this goal in MDS. So probably if we identify these patients as AML and treat it as AML patients, we probably are over-treating patients with an over-toxicity in the majority of this. There is a lot of debates about these two classifications. And in order to try to clarify these two entities, there is the first harmonization program that has been recently published by an international consortium trying to harmonize both classifications in one. With data-driven for more than 7,000 patients, they have identified at least these three classifications based on the genetic alteration, TP53, del5q, and SF3B1. And for the other patients that have not a specific genetic signature, they are going to be divided according to the percentage of blast. Probably it's the first step, probably will be the finish, we don't know, but let's try to harmonize, because to have those two classifications ongoing is completely a disaster for physicians, for patients, and even for clinical trials. Which one do you identify for clinical inclusion criteria, also for regulatories? So I think that we need to harmonize as possible. Let's finish with IPSS-M. As all you know, it's a novel molecular prognostication system for these patients that incorporate classical parameters, clinical parameters for IPSS, cytopenias, and cytogenetics, with novel somatic mutations in 31 genes that are related to prognosis. With these three type of variables, you can easily prognosticate the patients with this online calculator. And in a few seconds, if you have all this data, you can identify clearly the prognosis of your patient. Interestingly, in this novel prognostication system, they identify that there are three genes that are the top predictors of adverse outcome. And here you can see this one, and I like to highlight specifically TP53 multi-hit, that is the adverse prognostic gene nowadays, probably not able to improve outcome in this subset of patients. And interestingly also, they identify that SF3B1 mutations are not always associated with good prognosis. Here you can see that good prognosis is always associated only when the is isolated, but the presence of the concurrence with other mutations is important because it's associated with poor outcomes. So to the first question of our patients, male patients, probably we need to perform NGS in order to identify the pattern of commutations and to better stratify the prognosis. Here you can see the results of the IPSS-M. Is dividing the patients in two groups, not in three, like IPSS-R, low risk setting, near 60% of them, and high risk setting, near 42% of them, with moderate high, high, and very high, and moderate low, low, and very low. And as you can see, they are divided clearly with according to the overall survival, AML evolution, and leukemia-free survival. Interestingly, the question arises, do you need to perform in every patient, in all the patients, molecular IPSS? Here you can see a study in which they analyze the impact of calculate IPSS-M in this subgroup of patients with IPSS-R. And near 50% of the patients are restratified with the molecular IPSS. Interestingly, the majority of these patients are upgraded to a high degree of prognosis, and interestingly, the majority of the patients that increase the grade are in the lower risk setting. So probably in these categories of low and intermediate risk, probably it's necessary to perform molecular IPSS-M to identify better the prognosis and to adequate the treatment to these strategies. In patients within the high-risk categories, probably is not so relevant because they are moving from one high-risk category to other. Let's finishing with these three slides. I have to say that IPSS-M can help us to predict the response to some treatments, not to HMA, as previously commented Guillermo, but just in ESA treatment. And the Italian group demonstrated that incorporated to other classical variables that predict response to ESAs is able, IPSS-M score is able to increase this prediction model in order to identify which patient is going to respond to this therapy. And in this meeting, we are going to assist to the presentation of this small study for the Spanish colleagues, in which they are incorporated to the molecular IPSS classical variables in order to try to identify if these variables could improve the prognostication system of this novel prognostic system. And in this way, they identify that in patients with high-risk IPSS-M, the presence of transfusion dependency is impaired overall survival. And this is a reasonable and interesting way to try to improve these scores. Finally, I'd like to finish with this slide. Probably we need to identify a specific subgroup of patients based on molecular or genetic characteristics in order to test every drug in its specific context, because we will be able to identify the potential of the drug in its specific controls. And in this sense, there is a large database of MDS patients with molecular data, the validate cohort. It's presenting some data also in this meeting, and they analyze the impact of TP53 mutations when the patient receives hypomethylating agents. And they confirmed that response are the same, that the patients in wild type, and duration of the response was shortened, and it was associated with impaired overall survival in this setting. So probably we need to organize and identify this specific subgroup of diseases based on genetic or molecular features in order to try to put every drug in the same this specific context to make the potential of this drug. And that's all. Thank you very much. Let's move to Dr. Santini.
Thank you. So we had a very good introduction. Now we know what we're up to in rebooting a low-risk MDS management, new benchmarks and innovative sequential care. We have some new tools here. Now, we have Eric. Eric is the patient we got to know previously. He's typical in a way, but as you see here, he comes to the office with already transfusion dependence. Now, this is not so very typical in Europe because we have easier access to ESAs, and therefore patients are treated very early, usually. But in other countries, this is a very typical presentation, and we already got to know him as having ring sideroblast MDS or MDS with SF3B1 mutation, and he has experienced actually quite a heavy transfusion burden. So 6 units of red blood cells in 2 months. That means 3 transfusions a month. And what do you think of this situation? Are you acting, or you just tell the patient that can go on with some transfusions?
In our experience, I think that we need to treat early the patients, even after the development of transfusion. So probably in my country, we probably started with ESA previously in order to try to avoid transfusion. And of course, if the patient is diagnosed in the transfusion setting, of course, we need to start an intervention to avoid transfusions.
Then I have a little bit different question. Does command support first-line use of luspatercept in such a situation, or would you start with ESA and hold luspatercept afterwards in this specific patient? Guillermo.
In my opinion, is that the data from command support a wide use of luspatercept both in RS-positive patients like this one and as well in RS-negative. But there is some controversy about this. I'm sure we will be discussing this a little bit later in the question and answer.
Absolutely. And I think this is the right, let's say, right approach. But what about dosing the drug? Because these are patients who are quite engaging and quite difficult to treat.
I think of course, with the ESAs, they are all different dose schedules, different drugs.
Yeah, but especially luspatercept.
But with luspatercept, based on guidelines from the US FDA, we had to follow this dosing of 1.33, 1.75. Actually, mainly, I believe, as a safety issue, right? Like not trying to bring hemoglobins to really high levels that could be dangerous to our patients. I think that's actually, with all my respect to the agency, a little bit misguided because this very rarely happens in MDS.
Very rare.
So, but we have to follow those guidelines. And I believe there are European studies that you are both involved where you are studying, perhaps starting at a higher dose of this compound. If you allow me, actually, going back to the question, I think also going back to this issue of what drug is better or not in frontline, I think this issue of not letting these patients become overtly transfusion dependent, like this gentleman with 6 units already, is actually all the data that we have, including from Dr. Diaz-Campello with lenalidomide and so forth, is that this early intervention actually is more effective. And in that context, perhaps it's cost effective to use your best drug up front, but that's, again, personal bias.
Absolutely. So what about Eric if he hadn't had ring sideroblast nor SF3B1 mutation? Here we have RS negative, always low blast count in the bone marrow, but this time is XL1 mutation, same transfusion needs. What would you do? Again, it's negative. Would you use luspatercept first line, transfusion dependent, or ESAs? Or would you envisage the possibility to use both drugs in a combination?
Well, I think that there is enough data nowadays to combine both therapies, so probably this is not an option nowadays outside clinical trials. And regarding the presence of ASX1 mutation, probably could impair prognosis, but probably the patient is still in the lower risk setting, so probably they need to be treated as a lower risk patient, probably with caution. Probably you need to follow more frequently bone marrow and check what is happening with blast and clonal cytogenetic and clonal evolution. And probably, in my opinion, this should be more reasonable to receive probably luspatercept also, due to the fact that ESA patients that are responding to ESAs are those in a lower clonal evolution. And this patient with this mutation that is adverse probably is in a more advanced stage of the disease and probably is not the best candidate for ESA, in my opinion.
Absolutely. And on top is transfusion dependent, so the response will be lower anyway.
I think
so. Yeah.
It will also be very important, Dr. Santin, to know the EPO level on this patient.
Absolutely.
Yeah.
So actually, here I have to have a note. If you measure, not always, but if you measure EPO serum level in a patient who's receiving transfusion, usually is not so high. That does because it's suppressed by the transfusion. But nevertheless, it is a situation in which you don't see much response in treating with ESAs. And in fact, the recommendation for Eric, who's transfusion-dependent, low-risk first line, are to use in first-line luspatercept, as the evidence of commands indicates, because the responses, the percentage of response and the duration of response are prolonged with luspatercept versus ESA, is not yet approved in Europe, is approved only in the US. So we are waiting for this approval also in other countries. What about the RS negative? Okay, these patients, and I will show you, are also taking advantage of the treatment with luspatercept when transfusion dependent and ESA naive. And the dose escalation is very important to keep in mind. If the patient does not respond immediately, we have to continue the treatment. These are just two notes. ESA therapy should be started very early, before transfusion dependence. The dose are in between 30 to 60,000 units a week. And anyway, the patient will respond for different time frames, and usually they lose response, especially the ones with ring sideroblast. And the transfusion, chronic transfusion, we know that just bring with them iron overload, so we have to chelate. Not always the patient can be chelated efficiently because of renal insufficiency or because of other reason. It's a burden on patient, we just heard, and there is a risk that, in fact, these patients are rapidly evolving. So we have a tool now that is the use of luspatercept that we already mentioned. The mode of action is specific in terms of blocking SMAD2/3 signaling, because luspatercept is a fusion protein with a modified activin receptor 2B, an external part, stabilized with the Fc fragment of the Ig, and this means that it's trapping GDF8, GDF11, and also activin 2B. So the last stage erythropoiesis very well stimulated by this treatment, and this is why NCCN indicates in practice guideline that luspatercept should be used in first-line transfusion-dependent patients, both RS positive and negative. If EPO is below 500 in RS negative, and of course in second line we will see later, but again it's another indication that is very important. So it is a drug that is really helping these patients, and this is very clear from the COMMAND study. So if we treat transfusion-dependent low-risk MDS patient with luspatercept, we start with 1 milligrams per kilogram every 3 weeks, and you see that the achievement of increase in 1.5 gram deciliter and transfusion independence longer than 12 weeks has been reached by 63% of patients treated with luspatercept versus 42% of patients treated with ESAs. And this is why this drug was approved by FDA in first line. Not only the patient respond more, but the response is also longer when you treat with luspatercept. So you have 126 weeks versus almost half of it with ESAs. And what are the variables that may impact on this response? Actually, there are no impact on baseline transfusion burden. So our Eric will be in the group of patients with, as you see here, with more transfusion dependence, and he will not respond very probably to ESAs at all, or as you see here, very much less. And then EPO levels, of course, again, if you have very high EPO levels, you do not respond to ESAs. And then again, RS status in the long-term evaluation, the response is equivalent in RS positive or negative, transfusion-dependent low-risk MDS. And what about a very long response, duration of response? More than 1.5 years, you see in commands, the long-term analysis showed that more than 30% of the patients who received luspatercept and achieved transfusion independence had more than 1.5 years of transfusion independence. Also, if they were RS negative, also ring sideroblast negative, whereas only 13% of the patients who received ESA and responded were still keeping the response after 1.5 years. And baseline serum EPO is really not impacting, nor is the mutated SF3B1. They all respond. And if you wish to know more, there is on Saturday a very interesting oral abstract that I will suggest you to go to by my co-chair, Dr. Garcia-Manero. Safety. Commands showed that there are not really great safety issues. The patients are really safe with this drug. There is only one care to keep, that is to evaluate blood pressure before and after treatment, because severe hypertension may be worsened by treatment with luspatercept. But as you see here, there are no real great difference between luspatercept adverse event and EPO adverse event. So just take care of hypertension. There is no fear of an increase in progression of the disease. So what are the considerations for safety? Dosing, we start with 1 milligram per kilogram sub-Q every 3 weeks, but we may escalate to 1.75 in case the patient does not respond. Take care of noting transfusions and hemoglobin level, and then take care of a possible increase in blood pressure. So are we using this drug only in transfusion-dependent patients, or as Dr. Garcia-Manero was suggesting, would it be better to use it from the beginning? We do not have yet the data, but there is a study going on, the ELEMENT-MDS, that is focusing on non-transfusion-dependent MDS patients who have an hemoglobin level below 10 and specifically 9.5, kept for longer time, and they are treated with luspatercept and compared to ESAs. And the primary endpoint is to verify what is the delay in becoming transfusion dependent. And as you may see here, there are also other secondary endpoints. So we are very curious to see how this will go. Now, there was a question regarding the combination of the two drugs in non-RS positive, but also in general. And there is a study that is presented in this oral abstract on Saturday, as well tomorrow, by the French group. And few patients receiving high dose of luspatercept and APO alpha. And there was no disease progression. Some of them were already treated with ESA and were treated again with the combination. So I think this is something interesting to see. Eric again. But now Eric had received prior ESA therapy. And notwithstanding ESA therapy, he's now transfusion dependent. He needs transfusion after 18 months of ESAs. He's always the same. So 17% ring sideroblast, SF3B1 mutation, no blast in the bone marrow. And my question to my colleagues is, what happened here? ESA stopped working, and how do you judge the failure of ESA? What do you do when a patient loses response to ESAs? Maria.
Well, I think that he's failing because he's increasing transfusion requirements, and we probably stop the drug, reevaluate the disease again with bone marrow and genetics, and probably, if available, molecular markers to identify if the disease is the same, and change to another treatment.
If I may add something here, sometimes it's not a progression of disease, but it's just that iron is not, the functional iron is not good enough. I mean, it's more trivial, or B12 or folates or B6 are lacking. So usually I start from the easy things, and then I go to bone marrow evaluation.
Of course, you have to do this first, and if they are normal, you can proceed to bone marrow or something.
Now, I say that because also my younger colleagues are just going straight to bone marrow, which is correct.
Yeah.
But first, sometimes the reason is another one. And again, RS-positive patients do lose response very early. Okay, for Guillermo, what is the next step? So this patient lost response to ESAs. Do you switch to luspatercept? And does IMerge support imetelstat, a new drug, in this setting? What are the safety and dosing recommendations?
Actually, it's yes to both. Going back to the prior slide, I think something very important that we have not actually defined is actually how you determine an ESA failure. And this is actually quite important because we don't really have good guidelines, and probably from country to country this is very different. But in the United States, it is not unusual actually to see patients that have been transfusion dependent on an ESA for the longest period of time without switching therapies. And to be transparent, sometimes in the United States, some of this experience of adding, for instance, luspatercept to an ESA is not an active thought process from the clinician. It's like sometimes it appears that they don't even know that the patient is on ESA. This may sound actually kind of crazy. It's actually the reality.
No, absolutely. But in Europe as well.
Nurses and PAs giving these drugs are not really understanding what's happening. So I think at some point we need to really define what will be the proper time to switch from first line to second line anemic, like ESA to luspa, or if you're using luspa to whatever comes next. We don't 100% yet. Is this just one transfusion or some period of time?
Yeah.
So maybe we can work towards defining this.
No, I think this is an extremely important point because patients are really keen on keeping ESAs, even if they are transfusing, and sometimes you fight with them to stop. Or otherwise, as you mentioned, they come to receive luspa and you don't know that they're also receiving ESAs forever. So my suggestion is always to stop if you start transfusing and not do both together.
The next question is that you're totally correct. These patients don't tend to transform, so their cause of death is unlikely to be transformation to high-risk disease or AML. And I think the answers are both probably correct. It's going to depend a little bit on where you work and what is your context. So, for instance, today, probably attendee Anderson, this patient will have received luspatercept as first line. So, of course, you're not going to do that as second line. But the reality is that the first indication of luspatercept was for RS-positive patients that had failed an ESA or were not candidates for such a therapy. So if you live in that context, let's say maybe in some countries in Europe, then luspatercept will be a very good option. And now we're lucky that we have, at least in the United States for now, I don't know what the situation is in Europe, another compound as a second line that is this telomerase inhibitor imetelstat. Now, for us, this drug becomes really important right now, right? Because if we're switching from maybe ESA to luspatercept up front, we don't really have data from ESAs trying to rescue luspa failure, whereas the IMerge study, gives you some evidence of what this drug does in the second line, at least in ESA relapsed patients. And also for the audience to remember that the IMerge study, although it was designed for both RS-positive and RS-negative patients, actually, I think almost 2/3 of the patients were RS-positive. So I think this will be your options. If the patient was on ASA, Luspa, if it's on Luspa, then imetelstat will be a very good option. So we're really getting good at anemia.
Let's address this. And this is what you already mentioned. And this is a patient who had received first-line luspatercept. You already anticipated what we are going to discuss. So, Eric, second line, Luspa is an option based on the data of Medalist, and in Europe is still the only option. Imetelstat is approved, as you said, in the US, and is exactly for second-line patient who became transfusion dependent. And there are new evidence show that the imetelstat can be used after Luspa with some success. So what happened? Medalist showed that patients who lost response to ISA, because 96% of patients who were in Medalist had received before ISAs. And as you may see here, and if you may recall from the Medalist, 47.7% of patients responded with transfusion independence versus placebo here. But here you see that the patient had also a decrease in terms of transfusion needs, so the number of units received. And of course, the patients who received the maximal dose of the luspatercept were the majority, and some of them really achieved late response, but we have to keep this in mind and keep on treating these patients. We already mentioned imetelstat. Imetelstat is a specific telomerase inhibitor, has a completely different mechanism of action, of course, and is thought to be acting via telomerase inhibition. It has to be of course, demonstrated finally. But what is interesting is that apparently it really targets the dysplastic clone and has been approved by FDA in patients who are not responsive or lost response to ISAs and are transfusion or ineligible for ISA and are transfusion dependent. And of course, you see what I told you before, first line in patient with RS positive MDS, and this is in specific cases. Second line RS positive and negative. And as I mentioned to you, the activity is quite clear. 40% of patients have transfusion independence longer than 8 weeks, but 18%, as you see here, this is 6 weeks, 6 months, and more than 1 year are 18%. And these patients who have 18% have a very long duration of response. As you see, transfusion independence is much longer in all the patients who achieve the 8-week transfusion independence. 83% of them do have a very long, continuous red blood cell transfusion independent period. And this is clear from here. If you have 8 weeks transfusion independence, your duration of response is around 1 year. If you have 6 months of transfusion independence, the duration of response is more than 80 weeks. And if you have 1 year or more than 1 year response in terms of transfusion independence, your duration is 132 weeks. And what has been alluded to, and is very interesting and will be shown again tomorrow by Dr. Pletz-Becker, is that patients who received luspatercept, not only the ones who received ISA or were ISA ineligible, can respond with transfusion independence when treated with imetelstat. And what happens in terms of safety? Imetelstat is a drug that induces neutropenia and thrombocytopenia, transient, but still present. So we have to take care to avoid the drug in patients who are severely thrombocytopenic. But there are no signs of increased progression or increased AML evolution. Dosing, we start with 7.1 milligrams per kilogram IV every 4 weeks. This drug needs a little bit of pre-medication. And after 6 months of treatment, if there are no advantages, there is or toxicity, there is the advice to stop treatment, but there is also the possibility in case of grade 3-4 myelosuppressive event to lower the dose, as you may see here. And we can start going on with Dr. Garcia-Manero, who's taking care of the more risky patients. Thank you.
Thank you, Dr. Santini. So we're going to go to the last part of the symposium, and we're going to be talking about higher risk disease. And I believe Maria introduced the patient earlier. So this is a 66-year-old lady with MDS, comes actually with a significant symptom burden. So weight loss, dyspnea, fatigue, easy bruising, is anemic. Actually, she has a good platelet count still. Then in your bone marrow, you see 10% blast, and as we were discussing earlier, an AXL1 mutation. And I think when you approach such a patient in your clinic, the first question is going to be, is a stem cell transplant indicated or not in this particular patient? And what will be the outcome that you will expect with such intervention in a patient with a high-risk disease? Then the other question that you are going to be asked or you're going to be thinking about is there a need or if there is an optimal pre-stem cell transplantation strategy? And will that actually consist of hypomethylating agent-based therapy or not? And then, of course, if you had access to a clinical trial, will you consider that? So let me go and ask these questions from the two slides let's start with Maria maybe. So 66-year-old lady, high-risk disease. Let's forget about the mutations. Do you consider a stem cell transplant in those patients or not?
Yes, of course. We'll try to move the patient to the transplant and probably with a pretreatment strategy. I think that in Spain, we are now moving at combination therapies of azacitidine plus venetoclax combination to reduce the burden of the disease very fast and proceed to the transplant. And to the contrary to intensive chemo, the patient is outside, is not hospitalized, and has a better, I think, quality of life. And the quality of the response is very good with this combination. And we focus this strategy for this patient, especially in this with this mutation.
In my center, we have a little bit different approach. Now, this lady is borderline, 10% bone marrow blast. If we are up to 9, so a little bit less burden of disease, we may go straight forward to transplant without any therapy before. But of course, it is also a matter of how quick you can find a donor. So this lady is 66. If she has an HLA that preliminarily can find good donors, we would go directly, and if it's fast enough. Otherwise, I would just prepare as we mentioned. But of course, I discuss always with patients, you want to be cured or you want to survive?
What would happen if this patient, for instance, was like P53 mutated? How do you approach this same lady?
I would do the same. I have a lady like this in this very moment who is in the conditioning in this very moment. Now, this is, as you know, a very discussed issue. But on the other hand, if you have a TP53 mutated biallelic, especially, despite what we showed, but what do? They will respond to HMA for a very short time. The outcome of a transplant is very bad, as we know, but is better than 0. So survival at 5 years, as it has been shown recently, is 20%. To evaluate very clearly with the patient, because I don't think we have other options. All the specific inhibitors and reactivators failed. So I think, I don't know what you think, Maria, but I will go for transplant.
And what about Maria? Would you add venetoclax to this HMA bridge in a P53?
Yes. Even that the patient, only the reason why is only to be in a better situation of the disease, in a low burden of the disease to the transplant. Probably if the patient is not candidate to allotransplant, we did not add venetoclax, but in this context, we prefer to increase the rate of response, and the molecular response is associated to our improved outcome. So we started with both, yeah.
So to summarize this first part, I totally agree with Valeria and Maria that this is what I consider pediatric MDS, actually. 66-year-old baby, probably healthy. So the goal should be transplant. Actually, we were very sad this year because one of our faculty submitted to this meeting, and it was actually rejected, not even for publication, experience with 1,000 transplanted patients at MD Anderson. And the cure rate actually is around 50 to 60%. So I don't know what happened with that presentation. So we're really doing much better in terms of transplanting these patients at this age. So I think that should be the goal. And second, when it comes to the P53, I actually agree with this idea of adding the BCL2 inhibitor to the HMA because it may not prolong the survival outside the context of transplant, but the response rate actually significantly increased. So it may give you actually a better kind of disease burden when you take those patients to transplantation. Now, we are now very familiar with venetoclax because we had it approved for AML and CLL for a number of years now. They are not formally approved in the United States for MDS, but actually they are commonly used. So maybe Maria or Valeria can give us some of their experience with this particular drug in MDS. Is it the same use as in AML or not? What do you do here?
There you go, and then I see what.
I'll start. Probably the use is completely different. We have a shorter courses of the disease, shorter days. We only use it for 14 days and in a low dose of 400 milligrams per day. It's not needed the RAM because it's not frequent the tumor burden. So probably it's completely not the same that AML. And generally, these patients are not going to tolerate this scheme for more than 1 or 2 cycles, and the majority of them need to decrease the dose after 1 cycle to a lower number of days. From 14 to 7 days.
Are we talking about IDH1 mutation
next
or TP53?
Just venetoclax.
Okay. Venetoclax is off-label in Italy. We can't use it unless you do a lot of paperwork to use it. And I actually am very cautious. Of course, this lady who has probably no comorbidities and to my opinion is young, to her to be an MDS patient, she would probably, in view of transplant, receive venetoclax, but again, with a lot of attention to the toxicities. And here, if she would not be candidate to transplant, we have a sort of salvage afterwards.
So I think this is very, very important because the summary of this is that you probably will be using lower doses, and by lower doses of the venetoclax, we mean fewer days. So for instance, in our studies at MD Anderson, we tend to use an induction of 14 days, and maybe you will decrease. So we think that's an optimal dosing. And as Maria said, you don't really need these ramp-ups looking for tumor lysis. This actually very, very rarely happens in this patient population. Now, you may have a proliferative patient where you may need to bring down the white count maybe with hydroxyurea or something similar, and then you start with that combo. Now, what happens actually if this same patient has not a P53, not an XL1, but has an IDH1 mutation? And I think the answer is going to be very different from what country you live, maybe different in the United States than in Europe. But if you had access to an IDH1 inhibitor, will you use it? Will you combine it before transplant or not? Or actually, will you alternate if you don't have access to the IDH1 with a BCL2 inhibitor? So any of you may want to start?
We are starting to use it in a clinical trial because, of course, it's approved in the US only for relapsed refractory. In Europe, we do not have access unless we are in a clinical trial. I think it's a very interesting tool, a very interesting drug. Probably it could be also, as I mentioned, a salvage after Adzaven because of the good response to Adzaven, and then if relapse, we have another tool.
Maria?
Yes, it's the same, and we don't have access outside clinical trials, and in this regard, the French group is performing a clinical trial in first line with the drug in monotherapy with very interesting results. So probably it could be an option also without hypomethylating agents, but we don't have access to this in Europe.
So in the United States, there's at least one of the IDH1 inhibitors, ivosidenib, is actually approved for relapsed refractory IDH1 mutated MDS patients. And as Maria says, these actually are quite effective in combination as in monotherapy in second line. There's actually an international randomized study looking at IDH1 inhibition with ivosidenib in frontline patients. So this is going to be really important. Now, if you don't have access to these drugs, those patients tend to be sensitive to venetoclax. So sometimes we just replace one for the other. And actually at MD Anderson, we're already working on triplets where we combine IDH1 inhibitor, BCL2 inhibitor, HMA, and these are actually extremely effective therapies with very high levels of MRD negativity. Now, 66, I probably will still transplant this patient, and depending on the type of response, I will consider on some type of maintenance therapy. So basically, to start moving in some of the data here, I think the IPSS-M is quite important in assessing this high-risk situation. And Dr. Campello actually mentioned something that is quite important that we see, is this concept of upstaging. You know, patients that have lower risk disease by classic features like blood cytogenetics, that then when you put the molecular profile, they move on. And this is a group of patients that actually really benefit from using the IPSS-M. In addition, it may give you some hints of her therapy, as we mentioned earlier, IXL1, IDH1, IDH2. We're going to see that in the next few slides. There is some debate in terms of the optimal time for transplant, but we think actually that in the first 2 or 3 months of initiating therapy, you should probably take your patient to transplantation. And I think in a younger patient like the one we discussed, this is actually clearly the only way to cure this individual. Now, if you have access to a clinical trial of an innovative doublet or perhaps trying to switch the HMA backbone to something else, for sure, that will be quite important. And today in the United States, knowing your molecular status, particularly for IDH1 and IDH2, could actually give you a therapeutic option that is now approved for our patients. So these are basically some of the options that we have for these patients and some of the NCCN recommendations. I should mention actually that we have 2 IDH1 inhibitors in the United States, ivosidenib and olutasidenib. That's actually quite interesting. That are actually also being studied in clinical trials. There's actually a significant need for more clinical trials post-stem cell transplantation. This is something that we discussed, this concept of total therapy, that is what you do before transplant, how do you do transplant, and actually what do you do after the transplant. And I'm going to be showing you actually some data that is being, I think, pioneered at MD Anderson and moving also into acute myelogenous leukemia, is this idea of what we call total oral therapy. These are combinations with oral hypomethylating agents such as the cytarabine cedazuridimine, combined, for instance, with venetoclax, but this could be done with an IDH1 inhibitor or an IDH2. And I think there is a question that is starting to come out a little bit, and of course we're going to be discussing Verona in a minute, is this rebirth of, is there a role for some type of high-dose chemotherapy for some specific subset of patients with high-risk disease? That's for the transplant younger patients. The second is actually, what if your patient is not a transplant candidate because of age, comorbidities, etc.? Now, we still are in this situation where single-agent hypomethylating agent is kind of something that we have not been able to beat. We don't have formal approval of venetoclax in any country anywhere, but I think actually, at least in Europe, United States, is not uncommon, as Dr. Campello Santini were telling us earlier, to combine actually the HMA with venetoclax, and we already mentioned access to these oral hypomethylating agents, both in Europe and United States for AML and MDS. Now, this is actually why transplant is so important, and that's why I was sad about this MD Anderson poster not being accepted, because this analysis from the IBMTR is a hypothetical analysis, actually. This is a donor to no donor type of analysis. And what you see here is that if you have a donor, meaning that if you're a candidate for transplantation, actually you have a potential of surviving this disease of around 50%. If you go back to the prior analysis by IBMTR around 10 years ago, actually it was half of this. So we've done actually quite a bit of progress in transplanting our patients safer, with less mortality, less GVHD, etc., with relapse still being a major problem for our patients. The question is, why is there a rationale or not or what is the rationale for adding BCL2 inhibition to these patients? Of course, you could be cynical and say, well, they do that in AML, we're going to do that in MDS. Actually, I have to say, and there is people here from Genentech and AbbVie that may be aware of this or not, is that actually we were designing the MDS trials in parallel, actually a little bit earlier than the Viale study. So this is not something that we're just like transitioning from AML. There's actually quite a bit of data suggesting that this is an important mechanism of cell kill by inhibiting this particular pathway in these stem cells. Actually, data from Simona Cola and our group at the stem cell level actually has shown very significant molecular signatures that support the use of these drugs. And of course, the data in AML combining these agents, hypomethylating agent plus BCL2 inhibition, is actually quite significant. And we have actually the clinical data. So this actually, I believe, is impressed or accepted in blood. A very important phase 1 international study was presented at ASH several times, the last time by Dr. Jacqueline Garcia, the Dana Farber. And I think actually this is a very good example of what these combinations do. So this is actually the study that you may be familiar, combining azacitidine with venetoclax. You see the dose there of 400 milligrams orally for 14 days, please. Not 21 days, not 28 days. And what you see is actually an overall response rate that is over 80%, with close to 30% of these patients achieving a complete remission. Now, if I was showing this data 3 or 4 or 5 years ago, we would say, okay, this is like super perfect. This is going to be the new doublet. But over the last couple of years, we've seen some of the major phase 3 trials now starting to give us complete remission rates with single-agent HMA close to 30%, et cetera. So we, still really waiting to see the results of a study that you're going to see in a second. Now, at the beginning, and I don't want to put Maria on the spot, but some of my European colleagues were saying, oh, these are maybe toxic, maybe they are too complicated, etc. I think we've learned how to use these kind of combinations, and we think they are safe. But of course, this is not just giving single-agent HMA in a small practice and come back in a month. This requires significant effort by the clinicians, so you have to give prophylactic antibiotics to these patients. That's our opinion. You probably should admit some of these patients, not maybe for the whole month, but for a period of time during the induction course. That's what we do at MD Anderson. And if you do that actually in our hands, the mortality rate during the first 4 to 8 weeks is actually very low, close to 0%, let's say 1 to 2%. You will see more cytopenia than what you will see if you treat these patients with a single-agent hypomethylating agent. But as I show you, you double basically the response rate compared to historical data with a single-agent HMA. Now, this is kind of becoming our standard of care in North America, but we are all extremely eager to see the results of this phase 3 trial known as the Verona trial. This is going to be not only a pivotal study for our patients and for us, but actually what's going to dictate what's going to happen in high-risk MDS research, I think, over the next 5 to 10 years. If the study is positive, that is what we want. This is going to really transform the care of our patients. Otherwise, this is going to dictate actually how we design next-generation studies and so forth. You have to understand that, in my opinion, there is no doubt that this doublet is significantly more active. But the question that we are asking here is, does this improve survival or not? This is actually the key question. We need therapies that improve the survival of our patients in high-risk disease. Now, I mentioned earlier that there is also a shift towards these oral therapies, and I think the reason why we have the slides here is 2 different reasons. One is to highlight actually type of therapy that started actually maybe as a way to provide a more patient-friendly type of therapy approach, but I think it's becoming perhaps a more active way of treating these patients. So for many years, actually, we were interested in developing drugs such as oral azacitidine that is approved in acute myelogenous leukemia. And then we moved to this oral decitabine-cedazuridine concept. Here, the idea is that the cedazuridine blocks enzymatic activity non azacitidine deaminase, and by doing so, basically, you have the same levels of the oral decitabine that you will achieve IV. But actually, there may be more to the story because we're seeing significant activity with this compound. We have an oral presentation by Dr. Urruti on P53 mutated patients with actually significant outcome improvement with this particular intervention. So this may not just be a simpler way of treating these patients. But what is remarkable actually is the pilot data of the oral decitabine-cedazuridine in venetoclax combination that was published last year in Lancet Hematology from our group with an overall response rate of close to 95%. So we're really starting to reach levels of activity that are quite significant. Again, you have to take care of these patients. You have to give them prophylactic antibiotics. We tend to admit them a little bit, so the oral therapy doesn't really cover that, but you're looking at extremely active approaches. And then we're starting to slowly moving into incorporating some types of chemotherapy for our patients. So at MD Anderson, Dr. Kadia, Dr. Kantarian have been pioneering the use of all chemotherapies, such as cladribine at low doses, maybe with subcutaneous cytarabine, maybe with venetoclax. And in a summary that we presented by Dr. Bolougny, one of our junior faculty in the department, you're seeing actually really significant results with this kind of triplet nucleoside approach that is kind of like a step down from what we do in patients with acute myelogenous leukemia. This actually resembles French data with CPX as a bridge to transplantation with very high rates of response. So we may see a shift towards patients that we really want to go for transplant quite quickly with this kind of approaches. So we hopefully will see an improvement there. Then there is a question actually of maintenance therapy, particularly, of course, post-transplant. Again, this is the question of does venetoclax or BCL2 inhibition help us here? And this is will be presented also by Dr. Garcia at the meeting, as you see there on Monday, showing actually that you could do this post-transplant in combination with an HMA at lower doses, and this actually may prolong the response of some of these patients in this context of stem cell transplantation. Now, there are some take-home messages, and maybe for you that come to us and are spending the first few hours of the meeting here, this may be not necessary, but we see this in our practice every day. So this is quite important. This is not AML, so you don't give 28 days. If you do that, you're going to really promote quite significant myelosuppression. And if you forget to change that and you do this for 2 or 3 months, this may become a problem. TLS prophylaxis is not something that you really need to spend a lot of time thinking about because it doesn't really happen. And again, it is very important that you consider antimicrobials for your patients, that you consider antifungal therapy, and if you do so with an azole, please remember how to adjust the dose of the venetoclax on that particular context using the same guidelines that you will do as if you were treating a patient with acute myelogenous leukemia. We mentioned earlier that we're starting to develop some targeted approaches for these patients. So for IDH1, IDH2, remember there are patients with FLT3 mutated disease, NPM1 mutated disease, etc. But the one that is now approved is ivosidenib for those patients with relapse refractory disease. Now, these patients unfortunately are rare. We're talking about 2-3% at most of patients with MDS. And actually, I have to say that I'm grateful to both Servier and Rigel for be promoting actually this kind of interventions for our patients, because I think many other companies probably will say this is a super small niche market, who I will be interested on this kind of approach. So it's actually kind of nice to see frontline randomized studies with both agents coming out of these discoveries. These drugs are very active. They are oral. Actually, they are extremely well tolerated, and you have actually experience with them in patients with acute myelogenous leukemia. It's actually remarkable. So this is monotherapy with ivosidenib, giving you a complete remission rate of around 39%. So extremely active compounds that are well tolerated. And actually what is interesting is that you don't see the degree, for instance, of differentiation syndrome that you may see in AML or related conditions. So these compounds, as I mentioned earlier, are quite safe. This differentiation syndrome, if it occurs, actually is easy to manage and is not really a major problem. Okay. Now, the other interesting thing, and this was actually pioneered by Dr. Jorge Cortez when he was still at the MD Anderson, and I believe that there is a poster update on this, is that we have a second-generation IDH1 inhibitor, olutasidenib, that is also quite active and is being investigated in patients with MDS. So you see that from this data in monotherapy, response rate that is overall around 33% or so. And again, in combinations, close to 70% of these patients with IDH1 mutation are benefiting from this type of intervention. So really important data as well. Now, for the next slide, we don't have an indication per se. So this is something that you may not be able to do, and actually economical considerations are quite important also in North America. For some reason, this may not be that straightforward to obtain for your patients, but it's actually extremely effective. This is data from Dr. Corny DiNardo from our group, both in monotherapy and in combination, frontline and second-line patients with myelodysplastic syndrome, IDH2 mutated, with actually exceptional outcomes. Indeed, actually, for instance, monotherapy with this compound and axitinib in second line is giving us survivals that are now close to 30 months or so median. That is significantly better than the 4 to 6 months that you will see in patients with HMA failure disease. Again, These are not formally approved. I think the sponsor of this drug should really think about how to take this into kind of use for our patients, because this mutation is a little bit more frequent than the IDH1. Actually, maybe around 5 to a little bit less than 10% of the patients may have these particular same portions. So I think I learned a lot this morning. We learned about how to, diagnose, prognosticate these patients. We see a lot of progress in patients with lower risk disease. Actually, quite interesting to talk now. What do we use? Luspatercept, ESA, imetelstat, etc. So really, really important. High-risk disease, I think we're in a transition period. We're still kind of waiting, of course, to see what this doublet with venetoclax from the Verona trial is going to tell us. We are all hoping for positive results. But you're starting to see where this is moving. Total therapy, incorporation of transplant, post-transplant type of approaches. I think in the next couple of years, we're going to be in a situation where we're going to be saying that we're actually curing 50 to 60% of our patients with this disease. So hopefully I will be able to give that message at some point. And I think we have some time for questions. In IPSS-M high-risk MDS, RS negative on HMA, is there a role for luspatercept? Actually, interesting question. So are we ready to be using these compounds as adjunct therapy in high-risk disease?
Well, there is a study going on in Europe in high-risk MDS, I think. I have no idea of the data, if yet. There is a question live there.
Yes, remember, if you can use the iPad, it's a little bit better because there are people listening to us. Go ahead, doctor. Okay.
It's great for microphone.
I just saw a patient who's in his late 70s and has had mild monocytosis for years. Hemoglobin about 10 to 10.5. Platelets are normal. He refused a bone marrow. So I did NGS, comes back with TP53 and ASX. How would you treat this patient and how would you approach this patient?
Well, I think you need to really convince this individual to have a bone marrow test. It seems to me that this patient is very stable. I think the question will be, what will be the BAF of this P53 mutation? I think we saw a slide saying that mono versus biallelic doesn't really make a difference. I actually don't sure about this data because I have plenty of patients with low BAFs, 3, 4, 5 sitting for years and years. Nothing really happens. So I don't know about this. But Valeria?
May I add something regarding this specific case? Now, if he's in his late 70s and he doesn't want to have a bone marrow and he has TP53, but he's keeping 10 grams deciliter hemoglobin and I suppose normal platelets or near normal and just a mild monocytosis.
Total white count is not very high. It's been running between 4,000 to 6,000. It's just the monocytes have always been high. That's the reason I even did this.
Yeah, but I would just
sit tight and
just watch him carefully.
Sorry.
No, watch him carefully. If you don't have a diagnosis, you can't really do much.
The second patient I have is somebody who's been having anemia that became progressive, a little bit worse, and did a bone marrow. Platelets are normal. White count is starting to dip down to about between 2 to 3 with about 1,000 neutrophils and has 15% blasts. The regular FISH is negative. I don't have the NGS. I just sent it off. How would you approach that patient?
Maria, 15% of blasts? Yes, I think that probably is a high-risk NDS and normal cytogenetics. No, really? Probably you should treat with approval nowadays is only azacitidine. At least in Europe, you can choose between oral decitabine plus cedazuridine or azacitidine in monotherapy. The age was?
They're all bone
Okay, no transplant candidate, so go ahead with standard therapy with hypomethylating agents.
Okay, so we're actually getting a lot of questions. It's fantastic. It's an issue with the iPad. So question for Maria. Will you start higher dose of luspatercept now or not with all this discussion in someone with severe anemia? Will you use higher doses of luspatercept with the information that we have in someone with severe anemia? That's question number one.
Probably we need to wait until the results of the clinical trials. They are two ongoing, and probably high doses are going to be translated into a higher responses, probably, and a less time to reach response. But we have to wait until the LUS Plus trial and MAXI-LUS trial that are still ongoing.
The next one for Valeria. In treating RS-negative patients with MDS, why not combinations against luspa-ESA, luspa-lenalidomide? I don't know. What is your opinion?
Also, DALFAQ, Dan? All RS negative. Okay. We have some data, sporadic data, that as we discussed briefly, the association of luspatercept and ESA may, in fact, have more effect. But again, the French, the European study is going on, so we have to wait what it says. And the combination of imetelstat with something else has not been done. And we have data of lenalidomide plus ESAs and plus luspa. So I think data are coming. So, but nowadays we can't say more and definite answer to this.
So there's a question, again, the same, so I'm going to skip that. Question about transplant cytopenias. We already discussed the use of venetoclax in high-risk disease. This is an interesting question. Any differences in terms of MDS classification between the US and Europe? I don't think so, but what is your take on this?
Yeah, it depends if you are ICC or WHO. There are these two fronts, but you explained it very well, and I couldn't agree more. I mean, ICC is putting everything in the same box, and this is somehow good if you have a target therapy available that is available for AML, not for MDS, but it's confounding. And I keep on saying that we go back 20 years when we were treating MDS like that because with the high-dose AML therapy because we had no chances. So I still think that TP53 positive patients are completely apart, MDS and AML. But for the rest, I will stick to WHO and divide MDS from AML, clearly.
There's another interesting question, and this was discussed early on, not early on today, like a few years ago. So when we combine venetoclax with an HMA, should we consider about decreasing the dose of the HMA or not? How do you guys see that?
I was thinking to do this question to you because in Europe, generally, if you follow the Verona trial, and the patient developed toxicity, hematological toxicity, you need to decrease azacitidine dose. And is a thing that we never do in high-risk patients. And when we use venetoclax dose at clinical trials, we used to decrease venetoclax dose. We reduce generally the days of venetoclax for 14 to 70 to only 7. And this is, I think that this is under...
Same.
We try to keep the backbone as, we probably will decrease first the days of venetoclax and keep
then
the dose of
we
the
could do the 3
hypomethylating
days, as you suggest, MD Anderson, but this is more for lower risk. So,
and there's a question about age. So, for instance, these drugs, luspatercept, imetelstat, etc., in people older than 80. Do you have any questions about using them in like people that are a little bit older or not?
Not really.
No, not really.
The venetoclax is a little bit careful for the myelosuppressive effect and the frailty of the patient. The other ones, I wouldn't say so. I have a couple of patients older than 80 who are receiving imetelstat. And I have many who receive luspatercept older than 80.
Yes, in Spain, it's also very frequent that have several patients more than 85. So
plus, this is the age of this disease in a way, right? So I totally agree with this. Now, there's another interesting question that is a patient with fibrosis, elevated blast. How do you treat? Do you treat as AML? I think the first issue when you see this kind of patient, you automatically should think about the presence of a P53 mutation. I know in some countries this may not be that straightforward, so you may then ask your pathologist to do some immunostaining for the P53. There's actually quite nice data suggesting that you can replace NGS by just simple protein assay. Actually, I think this is a great example of why this disease is not AML. Because if you give someone with P53, severe fibrosis, excess blast, you start treating them like an AML, you're going to be in trouble actually pretty quickly. So actually those patients is when you may really think about single-agent HMA, these are very difficult patients. So that was really excellent question.
It's a real challenge. MF3, it's really hard to
Then someone is asking an important question, and we have not really discussed it, that is, what about these RAS mutations that we see very frequently? A colleague was asking about CMML patient, but this is actually a target that people are starting to think as a therapeutic. Any ideas about this?
No, we would like to have specific targeted therapies in MDS, but we don't. We should probably get them from solid tumors, or because we do get a lot of patients with NRAS and KRAS and
Very bad outcomes.
Then there was a very important question is, how far do you push ESA dosing before considering failure? We addressed that early on, right? That we don't really have good guidelines. Maybe we should really work on this.
So the Italian guidelines, they're very old, but they would say 6 months. And then if you don't have any improvement, you stop.
We're running out of time, but 2 questions, because I think these are very important but for both of you. So what do we know about imetelstat in luspa failure? And then I'm going to give you the second one, because I think they're going to shut. This is more for Valeria. What about any role for lenalidomide in 5q minus, and I guess non-del 5q minus disease? You led those studies.
Yes. Well, it was a failure in the sense that the company didn't develop the drug. But in fact, we could demonstrate that 30% of patients would achieve transfusion independence. And among these, 46% who had low EPO levels at the moment of losing response were responding very well to lenalidomide. Then everything stopped. We couldn't find actually a molecular signature that could tell us what to do. But again, before we had all these other options, sometimes we were using lenalidomide in patients who were MDS del 5q negative. And in some cases, I could tell you at least a bunch of patients who had very long response in terms of transfusion independence. So.
What about the imetelstat after luspa? Do we have any experience?
I have a couple of patients who received imetelstat in the clinical trial of the QTC part last, who received luspatercept, imetelstat after luspatercept. As you saw, when we analyzed all the cases, 29% responded. So it's third line. So.
I think we're at the end. This has been really a lot of fun for me. I'm really grateful for the support of the organizers and the sponsors, and to have you all here at 7 in the morning when we started early on. So thank you very much. And we wish you a super ASH and a safe trip back home, and with a lot of knowledge for our patients. Thank you very much. And thank you, Valeria and Maria.
Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, HealthTree Foundation for Myelodysplastic Syndromes. This activity is supported through independent educational grants from AbbVie, Bristol Myers Squibb, and Geron. To access all materials for this activity, visit peerview.com/XNT860.